everyone. Assalamualaikum warahmatullahi wabarakatuh. So we are going to continue our discussions before lunch. Again, this is regarding the progesterone topic as a luteal phase support in IVF. So as introductions, we know that luteal phase is defined as the period between ovulations and establishment of pregnancy or the onset of menstruation or menses. So that's why if we talk about luteal phase support, it means that we administration of the drugs for supporting embryo implantations after the patient ovulation or after we do embryo transfer. How luteal phase insufficiency happens or out phase? Right now we recognize it as an out phase. Out phases happen if there's a dysynchrony endometrium phase between endometrium phase with ovarian phase. If the lack of dysynchrony more than 2 days, so we call it out phase or the patient suffering from luteal phase insufficiency. It is happened because of inadequate progesterone secretion by corpus luteum, or the response of endometrium to progesterone is not adequate because there is no progesterone priming before. So that's why the priming of estrogen before is very, very important. It means that folliculogenesis should be happen very well before we have a good corpus luteum. So how do we support luteal phase if we found any luteal phase insufficiency? As Dr. Gita mentioned before, in IVF, actually we do iatrogenic luteal phase insufficiency because of our intention to do the ovarian stimulations very well. A lot of corpora lutea will suppress LH receptors in the pituitary. So we can support luteal phase through save corpus luteum by giving injection of HCG to save the corpus luteum, or we give replacement of the product or corpus luteum by giving progesterone or in combinations with estrogen as well. So the role of progesterone is very important, as previous speaker mentioned, starting from facilitating implantations and also supporting the corpus luteum, and then the modulate the immune response, if prevent rejection of embryo. Dr. Kanadi mentioned the role of TH2 is very important during implantation process. So if we give administration of luteal phase support by progesterones, it means we want to transform endometrium from proliferative phase to secretory phase. By ultrasound, we can see very clearly the triple line or trilaminar pattern in the endometrium because of high estrogen levels. And if the ovulation happens, the triple line or trilaminar pattern was disappeared starting from the basal endometrium because of the progesterone rising. It happens. So if we found this disappear of trilaminar, it means maybe the transformation is gone. The transformation happens. So we can see in these tables the transformational dose. Each progesterone type is really different. If you want to use the progesterones, they need at least 4,200 milligrams per cycle to transform endometrium. The daily dose, we need at least 200 until 300 milligrams daily if we use natural progesterones. And if we use dydrogesterones, we need only around 10 to 20 milligrams daily, up to 30 milligrams daily for up to 140 milligrams per cycle to transform endometrium. So we have 3 choices of progesterone that we can give to our patients. We want to choose vaginal preparations, injectable or oral or tablet progesterones. And we can starting from the day of OPU until at least day 4 after egg retrieval, in order to make a good supplementation to prevent luteal phase insufficiency in IVF. If we look at the comparisons of oral, intramuscular or injectable or vaginal progesterone, we can in fact, in oral, we can find very low level in the blood, bioavailability less than 10%, and very high, the dose that we need, up to 600 milligram daily. If you want to transform endometrium, use orally progesterone. If you use vaginal progesterone, it's a low level in the blood, but still causing endometrial transformation, and it's very important first uterine past IVF. And if you use intramuscularly very high level in the blood within 2 hours, but very low in endometrium. So that's why it's very important which kind of progesterone we choose for giving luteal phase support in our patients. What is the dydrogesterone? This is actually the retroprogesterone, because there's a bad technology, that there's a bad. This is a close stereoisomer of progesterone, additional double bond between carbon 6 and 7 with high oral bioavailability, because of this is 28% compared only 6 to 8% for men. The other important things also in luteal phase support, right now we recognize individualized luteal phase support. It's quite depend on the drug that we use for the trigger. If we use HCG or if we use agonist trigger. Of course, if we use agonist trigger, we want to do fresh transfer. We should make a combinations between progesterone injections with micronized progesterone or slow dose HCG. But if we use HCG, we can use anything of luteal phase support regimens. We can use vaginal, we can use oral, even we can use rectal, or we can use injectable progesterone. The very interesting study, I think, is almost 10 years ago, Lotus 1 and Lotus 2 and Lotus 3, clinical non-inferiority clinical trial. Yeah, I think Mufri mentioned before by John Grisinger and Herman Turnaye. The Lotus 1, they want to see how the dydrogesterone is non-inferior compared to micronized vaginal progesterone in fresh transfer. You can see this is a very good design protocol. It's a randomized control trial. I think more than 400 subjects. This is the first arm, dydrogesterone 3 times a day, and then the second arm, micronized progesterone 3 times a day, 600 milligrams. Evaluation on week 4, week 3 after ET, and then up to 6 months after delivery. So they follow all the outcome of the IVF program after giving luteal phase support. This is the orally dydrogesterone. This is micronized vaginal progesterone. I think more than 400 subjects. Total population 974. I think there are no difference in terms of embryo transfer, day of embryo. There is no difference. And then we can see here in the 12 weeks, the dydrogesterone demonstrating non-inferiority compared to micronized progesterone in terms of 4 weeks gestation, during 4 weeks gestational age, 8 weeks, 12 weeks, and then live birth rate. No difference between two groups. So it means that dydrogesterone is non-inferior compared to micronized vaginal progesterone in fresh transfer. And also toward the infant safety, there is no difference up to, I think, upward skull and the gender, and also abnormal finding on physical examinations. The next trial is Lotus 2. This is also non-inferiority clinical trial. I think by Grisinger, they are trying to compare the dydrogesterone with vaginal gel, micronized vaginal progesterone gel, 90 milligrams, again in the fresh transfer. The same design, still the same protocols. This is orally 3 times a day. This is only once a day, 90 milligrams daily. Again, the follow-up up to 30 days after delivery. There is no difference in outcome of pregnancy. The number of the subject also 980. No difference of the embryo transfer, number of embryo transfer, and then also Lotus 2. There is no issue in terms of the safety of neonatals. Again, pregnancy and live birth rate post-treatment. This is at 12 weeks. No difference in 4 weeks, 8 weeks, and 12 week gestational, and also live birth rate between oral dydrogesterone with micronized vaginal progesterone gel. So again, this is non-inferiority between dydrogesterone compared to micronized vaginal progesterone gel. The infant status also no difference, the number of newborn and then abnormal findings, body weight and Apgar score, no difference between two protocols. And if you look, this is the Lotus 2, Lotus 3, this compare Lotus 1 and Lotus 3 in aggregate data. Actually, there's an increasing favoring, slightly increased to oral dydrogesterone compared to micronized vaginal progesterone in fresh embryo transfer. And the very interesting data and study also addressed by Barbara Lawrence and Iman Fatemi. This is again the systemic progesterone levels. Is it reflecting dynamic of endometrial changes or not? Because, it is because there is a difference of progesterone preparations or progesterone regimens. Fatemi mentioned in this study, I think the study by Hall, to see how the conception cycles, this is the mean level of progesterone is around between 8.5 until 16.7 nanogram per milliliter. And also Nakajima, this is the range of progesterone level between 8.6 until 34.8 nanogram per milliliter. The progesterone level obtained from spontaneous conception cycles. I think before there's a question from the audience, the previous sessions. So if we look the different progesterone administration routes, daily doses and time interval until the peak concentration in the systemic circulations, it is really different between every application route. This is vaginal rectal. For example, we use 300 until 600 milligram daily, and then the time interval until peak serum progesterone, it needs 3 to 8 hours after vaginal applications. Intramuscular injection, this is 25 milligram daily, rapidly rise after 2 hours. If we use dydrogesterone, the progesterone levels are not detectable by commonly used progesterone assay. And a subcutaneous injection, 25 milligram daily, peak after 0.9 hours. So I think it's really different. It depends on the load and also depends on the regimen that we use. The other study also very interesting, again by Barbara Lawrence, trying to see how the combination between dydrogesterone and micronized vaginal progesterone can save the serum progesterone level measurement on the day of embryo transfer and rescue time unnecessary in hormone replacement treatment in frozen embryo transfer. I think no matter the serum progesterone is below or more than 10 nanogram per milliliter in the day of the frozen embryo transfer or 1 day before embryo transfer, there is no significant difference on ongoing pregnancy rate. I think it's very important the combination between dydrogesterone with micronized vaginal progesterone to rescue the serum progesterone before we do frozen embryo transfer. And then this is also, again, just want to see how safety dydrogesterone compared to micronized progesterone equally safe for the newborn. Or congenital family genetic disorder, congenital heart disease, newborn cases, I think Mukhri already explained comprehensively in the previous presentations. The next, this is our data in Yasmin IVF clinics within 1 year. All the frozen embryo transfers we did in our centers, and this is all the hormone replacement therapy or artificial cycles. We use combination between estradiol tablet or gel with combination of dydrogesterone and progesterone gel or pessary. And I think this is very good data. I think in the endometrial thickness there is no difference. And then the pregnancy rates, I think 100 to 28 over 350, I think is around 40 to 50%. The number of embryo replacement, the day of embryo most likely blastocyst transfer. So I think we did not check regularly serum progesterone before frozen embryo transfer, but we use combination between dydrogesterone with micronized vaginal progesterone gel in HRT cycle or artificial cycle. So as Barbara Lawrence mentioned, that the combination can save the success rate without disturbing the serum progesterone level before frozen embryo transfer. And this is also the data regarding the comfortable if we use the patient use the dydrogesterones. I think this is the gel, the vaginal bleeding and the vaginal discharge. A lot of patients suffering from a lot of more patients suffering from vaginal bleedings. And then this is also absolutely satisfaction of the dydrogesterone. I think it is higher orally. I think compared to the vaginal pessary, I think we know this from all of our patients, which is they are able to use the tablet, of course, compared to the vaginal tablet. Then this is the old data, I think is more than 10 years ago, did by our center by Dr. Kanani. We are trying to give dydrogesterone twice daily, in the first semester of pregnancy, and then compare with the folic acid alone, and then after 4 weeks, we measure the placental growth factor or PLGF. And then the group who receives dydrogesterone twice daily, they will have a higher, significantly placental growth factor compared to the group only receive folic acid. So it means that the dydrogesterone facilitating the invasiveness, trophoblast invasiveness much more better compared to other progesterone. So that's why another study also from group from Malaysia, I think from Mohri College in Malaysia, they prove that the patients that receive dydrogesterone as luteal phase support, they're suffering from lower for severe preeclampsia in the second and the third trimester. It is because of placental invasiveness and trophoblast invasiveness. It must be better because the group of dydrogesterone they have placental growth factor higher compared to other progesterones. And the last, if we compare all the three luteal phase support regimens, we have dydrogesterone. Now we use 3 times, not twice, 3 times a day, 30 milligrams daily, progesterone water-based, or progesterone micronized vaginally, rectally, or even orally, the 600 milligrams daily, or HCG injection. I think live birth will not different. If we look the coherent database, all the live birth was not different. The dydrogesterone also is not inferior. I think we only think about the safety, the comfortable of the patients, and also the side effect maybe to the patients. The last, as a take-home message, is we know that luteal phase support is very important, a contributing factor toward pregnancy. Therefore, should be given under individualized approach. Please remember how we trigger the patients, and then selected progesterone preparation approach and dosage in daily practice should take into transformational dose. It's very important, the transformational dose. And serum progesterone level do not reflect endometrial progesterone level. It is very important, yes. So that's why this is still debatable and still very interesting to be discussed further. The dydrogesterone look promising in preparation endometrial transfer with non-inferiority compared to natural progesterone or micronized progesterone in terms of IVF outcomes and newborn safety. Thank you so much for your kind attention.